desde aquí vamos a informar. Tenemos como
Yes.
siempre esta gráfica que
Right.
ilustra cómo se ha presentado la enfermedad desde el 1 de enero
All right, let's begin with the
hasta
daily technical
la fecha de
report. We
hoy
have this
y
chart, as usual,
cómo se ha
that
presentado en las
informs
distintas
us as
regiones del
to how
mundo,
the
donde se presenta
disease
la
has
China, que
manifested
fue la región predominante,
itself throughout
después
the
encontramos
world.
el sureste asiático,
We have the different
después se
regions
encontró
represented
la
in
región
these different
europea de
colors.
color azul
First, we
y
have the
recientemente la
Asian
región de
regions,
América.
then we have the
Vemos también
European
aquí
region,
los
and
casos que
more
se han
recently
registrado
the
en las
Americas
últimas
entered
24
the
horas
pandemic.
y
Here we
el
have
porcentaje de distribución de estos
the
casos
percentage
y
of
vemos que ya, tal como
the
lo veníamos
cases
observando,
that are the
la
ones
región
that
de
have
América
appeared during the
supera
past 14
a la
days and
región
are
de
currently
Europa
active.
en
And we
cuanto al
can
número
see
de
how
casos
now,
registrado en las
finally,
últimas
the
24
Americas
horas.
are
Esto lo que quiere decir es que en este momento ya la región
presenting
de América
a
tiene una
higher percentage
epidemia
than the European
más
region,
activa,
which means
más
the
reciente,
pandemic is
mientras que
now
Europa
active
empieza a encontrar
in a
ya
more
un
intense
punto de
way in the
estabilidad
Americas,
y
while
empieza a
the
descender el
European
número de
region
casos
is
diarios.
finally
Si bien la
stabilizing
tendencia
and
para
starting
Europa, que
to
hasta el momento ha sido
slowly
la
come
región
out
más
of the
afectada
epidemic.
del mundo,
This is great
la buena
news
noticia de
because
esta
Europe has
situación
been
respecto
one
a
of the
América
most
es que
affected
Europa
areas
estamos
in
en
the
la fase
world.
ascendente, incluido
And
desde luego
well,
México,
we
como lo hemos
continue
dicho
to
otras
be
veces.
on the
Recordar
upward
que estos datos
trend
proceden de la
side of
Organización
the
Mundial de la Salud, que
of
es la
things.
entidad que compila todos los datos mundiales
This
y
information, as we've
tenemos ya
said, is
acumulados más de
directly
2
sourced from
millones
the World Health
160 mil casos,
Organization.
considerando desde el caso 1 que se
And
presentó en China al inicio del
now
año.
we have over
También
2 million
un
cases
poco más de la
globally,
mitad
considering the
son
first
casos recientes,
case
es
that
decir,
started
casos de
in
los últimos
China.
14 días, pero también ahí hemos encontrado ya
And
desde hace 10 días una buena noticia
we
en el
have
sentido de que
had some
disminuye
good
la
news
proporción de casos que se
as
presentan
well
en las
when
últimas
talking
24
about the
horas.
proportion of
Sin embargo,
active
esta
cases.
cifra muy probablemente
That
va a
is a
desaparecer
percentage
con
that
el
has
tiempo
been
y en algún
decreasing during
momento
the
entrará en estabilidad y
last few
probablemente va a
days.
empezar a volver a aumentar
However,
en la medida
this
en que la
number
epidemia
is
por
probably
variantes
gonna go
Delta
down,
siga avanzando
but
sobre esta fase
then continue to
ascendente
go
a
down
una
and
epidemia
then
más reciente.
stabilize, and then it
La
might come up again
letalidad y
as
el
we,
porcentaje de
the
personas que
Americas, move
desafortunadamente
into the
pierden
most
la vida
intense phase of
entre
the
aquellas que
pandemic.
tienen COVID está también en un aumento lento, pero sobre todo
The
desde que
fatality
la noticia
rate
se propagó
is
fuera de
also
China.
slowly
La siguiente.
but
En el
constantly
panorama
increasing.
internacional también cabe
We
destacar
have
este
also
entrecruzamiento entre la frecuencia en Europa y la frecuencia
an
en
intersection
América
between the
para los
frequency
casos de
in
los
Europe
últimos
and
14
the
días.
frequency in
Recuerden, la
the
gráfica
Americas
anterior era para
for the
todos los
cases
casos, esta es
during the past
específicamente
14
para
days.
los casos
The
recientes. O
last,
sea,
the last
que
graphic
en
was
este
all of the
momento
cases,
todavía
taking
se
into account
mantienen
all of the
casos
cases of the
recientes
pandemic.
y
But this
han
chart
recordado que
specifically
teníamos
is
a la región de
referring to
América aquí
the
arriba y ahora ha
cases
pasado acá abajo en la medida en que están ordenados
just taking
de
into
acuerdo
account the
a
last 14
la
days.
frecuencia o a la proporción.
This is the
América ya
proportion
tiene
during
apenas
the
un
past
poquito
14
más
days.
de casos en las
America
últimas
has
24 horas
effectively
respecto a
surpassed
Europa
the
y la tendencia
European
será
region.
la reducción
And
de la
the
situación en
trend will
Europa
continue
y
to
el
be
aumento
that
de la situación
the
de transmisión en América.
that
La siguiente, por
the
favor.
European region will be less and less
El panorama
represented in this
nacional,
chart, and the Americas
aproximadamente el
will
mapa está
continue to be
pintado en color
overrepresented
amarillo
in this chart.
y
Here
algunas
we have the
zonas de
national
color rojo, lo
situation.
que
We have
significa, lo hemos
a lot
dicho,
of areas in
recordamos
yellow,
para quien no haya
and
visto el
some
mapa,
areas are
esta
now
muestra
showing in
la
orange and
frecuencia de
red.
casos que se presentan y se
This
confirman
is
en las
related
entidades
to the
federativas y
concentration of
hay una
cases
escala
per state.
en estos intervalos de 1 a 50, 51 a
And
100,
we have a
etcétera,
scale
hasta
1 to
llegar
50
mínimo a
cases,
3000
50 to
y desde
100,
luego
all
en
the way
otro dato
to
pudiera haber más de 3000
1000
casos
to 3000.
confirmados en una
This is
misma
what the
región
color
y
sections
aquí seguirá
indicate.
extendiendo
And of
esta
course, we can
categorización.
reach the
Aquí hemos agregado ahora el
this
número de entidades
situation in which we
federativas o
have
estados
over
que se encuentran en esa condición.
3000 cases
La
at
Ciudad
some
de
point.
México y la zona
Um, the only
conurbada
states,
del Valle de
the
México,
only
lo que pertenece
state that is
administrativamente
on
al
the
Estado de México, es
on
esta
the
zona,
red
esta región
brown
donde tenemos la máxima
color
afectación.
is the
¿Cuáles son
Mexico
las zonas?
Valley city
Tenemos
area,
aquí
which is
en la franja
considered as
30,
one
cerca del
entity.
23%
And
con
it
casos,
is
23% de hecho,
natural
de la
that it
población
is the
mexicana
place with the highest
vive en
concentration
esta
of cases
zona
because
central en
it
el
is
Valle de México. Se han acumulado
the area with the
7.497
highest
casos
population as
desde el
well.
28 de febrero, cuando México
To this day,
notificó a su primer caso
we have
confirmado.
accumulated since
Se han registrado
February
40
28th,
muertos,
which
es decir,
was day
7.7
one of the
lamentablemente
epidemic for
infectados
us.
por el
To this
SARS-CoV-2,
day, we have
personas que
accumulated
habían fallecido por la variante de
7,490
COVID,
confirmed cases.
20.301.
There's been
Recientemente también tenemos a
12,369
150 personas que han
negative cases. We
fallecido
have over
como consecuencia
29,000
de esta enfermedad.
suspect cases, and unfortunately to this day we have 650 fatalities related to this disease. Here we have the same information presented in the form of a bar graph, in which we can more clearly observe the number of cases identified per state. Let's emphasize, and we will continue to emphasize this throughout the following weeks, all the way until we reach the peak of the epidemic, the national epidemic, that we've said we think we're gonna peak during the second week of May. And what we'll be emphasizing is this distribution that is, in a way, heterogeneous, is unequal, an unequal distribution among states, because we have some states that have a very high concentration of cases and some states that are barely showing any transmission. It is clear that the Mexico Valley City area, the Mexico City and metropolitan area, just because they have the highest concentration of people in the whole country, they are expected to have the highest concentration of cases. It is not comparable, the amount of cases in this, the number of cases in this area to the number of cases in a less populated area. And that is why we use a very useful indicator, which is the accumulated incidence rate, which is the amount of cases per 100,000 inhabitants in a particular area. And this is the distribution we have as a result. So we can see how, even taking the population into account, the Mexico Valley City area still has the most active transmission of this virus, but also the area of Monterrey, the area of Guadalajara, the two Baja Californias, particularly the northern region that borders the United States, and Sinaloa, the most intense transmission area, is of course the capital, Sinaloa, Culiacan. It's the same information presented in the form of a bar graph. We can compare visually in terms of the height of each bar. This is the incidence per 100,000 inhabitants. On average, we have an incidence of confirmed cases of 5.86, and this number will continue to increase until we reach the highest number of cases per day, the most intense stage of the pandemic in our country. Here we have another map. It is important to pay attention to the interpretation and analyze this map carefully. And we've seen a great interest from many members of the population of the Mexican people in this map. And I think it is a great thing that many people from many areas of expertise or not expertise and from many walks of life are interested in this map. Because this is a short conference, we cannot go into a lot of detail. We're barely showing these maps, but as we have said, if you enter the link below, you will have access to the same map, but in an interactive way. You can zoom in, zoom out, you can appreciate exactly which municipalities have what number of cases, and it is much more user-friendly and much more specific. So we invite all of the people who are invited in this information to access directly through the website this map. And thank you to CONACYT that has coordinated the efforts to unify and process this information in order to present it to the public. And this has taken the collaboration of a lot of academic and scientific research institutions of our country, universities being included, of course, mainly public universities. This is the age distribution. There are no relevant changes. We have two different groups. The green bars represent the outpatients, the yellow bars represent the inpatients. And let's remember that this is in most cases that exhibit mild symptoms, this is a disease that will that has a natural process of infection and then recovery. But those people who are over 60 or are pregnant women or have any sort of pre-existing conditions such as obesity, hypertension, pulmonary disease, kidney failure, immunosuppression of any kind, they are at a higher risk. And we can take a look at the age distribution here, and we have a trend that has been stable throughout the past weeks, and that trend is that the older the citizen is, the more likely they are to require hospitalization. So as you can see, for the age group that for the younger age groups, most of the patients are outpatients. They do not require medical care within a hospital. But as the age groups go up, the amount of patients that need to be hospitalized also go up. And we have made the comparison with the European countries in which there is an older population overall. But here in Mexico, even though we have a younger population overall, we also have a younger prevalence and a much more visible prevalence of this disease in younger people, and this is closely related to all of the conditions that are very prevalent in our society and are a product of malnourishment and just bad nutrition habits. Here we have the distribution of the clinical status of these patients that has been basically the same throughout the past few days. So we have 63% of outpatients, 10% of hospitalized patients that are stable, over 20% of severe condition hospitalized patients, and just short of 5% of patients that have been intubated. These patients unfortunately reach a critical state in which they cannot breathe on their own, and that's when we use what we call a mechanical ventilator. Some people call it a mechanical breather to help them breathe. Here is an anecdote that is somewhat related to this that was presented to me by some colleagues from medical practitioners, and I want to relate this anecdote. This is a real story because it can clear some doubts within the population. This was an unfortunate situation because the outcome was a severe case, but I don't want this anecdote to the fact that it's a sad story. I don't want it to prevent us from using this as an example to the population. This was a person of less of 60 years old that attended a public hospital, a COVID special hospital, and he was sort of confused, and he expressed some concern because he said the relatives had told him that he had pulmonary disease, and now he said they told me that I had pulmonary disease. Pulmonary disease meaning pneumonia. Pneumonia is the medical term, and it is a condition in the lungs that is associated usually with infectious causes. So he was confused because he said, they told me I had pneumonia, and now you're telling me that I have COVID. And so this story is important because some people don't quite understand yet what is the difference between pneumonia and COVID. So let me clear this out for you. The mild version of the disease of COVID is a disease that causes irritation or inflammation of the respiratory tract, which begins at the nostrils, goes through the inner part of the throat, where the vocal cords are. Then it goes to the bronchi and finally reaches the lungs. The lungs are the specialized organs that get air inside our bodies so we can provide oxygen to our blood. And oxygen is very important because it helps all of the cells within our bodies to carry out their designed functions. Then blood gathers another gas which is called carbon dioxide. So basically what the blood does is delivers the oxygen, gathers the carbon dioxide, and then brings it back to the lungs, and then we liberate that carbon dioxide through the lungs, from the lungs in an inverse manner, from the lungs to the bronchi, to the throat, and then to the nose, and then we expel it. This is what happens under normal conditions. If you have COVID, on the mild version of COVID, you have the superior part of your respiratory tract that becomes inflamed or irritated. And this explains the symptoms of COVID, which are throat ache, sometimes sneezing, and fever. Because, fever is caused by a more general mechanism in which, when we are subjected to an infectious process, there is a response from our body, and part of that response is the fever. So that is the mild version of COVID. Now, what is the severe version of COVID? Well, this same virus could reach the inferior parts of the respiratory apparatus. When that happens, the lung tissue becomes inflamed, and there are some microscopic damage to the microscopic circulation of the lungs, and they can become obstructed in a general way. When this happens, the area in which the exchange of oxygen for carbon dioxide happens stops working. So this interchange, this exchange between these two gases cannot happen anymore. And then this results in the deprivation of oxygen from the blood. So this is what we call acute pulmonary damage, and is usually a combination of different types of damage: damage by inflammation, damage by obstruction. So anyway, for pragmatical uses, this is equivalent to having a pneumonia. So going back to the history, to the story I was sharing with you, the severe version of COVID can be, for all intents and purposes, considered to be a form of pneumonia. So this pneumonia is what leads to people that have the severe version of COVID needing a respiratory supporting device, because otherwise they cannot breathe on their own, and this can have a fatal outcome. Right, next one. In this case that we showed, we've been showing for over a week, we have the confirmed cases, but also the suspect cases. The suspect cases are people of any age that present the symptoms that are related to COVID: fever, coughing, throat ache, nose secretions, muscle pain, etc. So these people who are considered subject cases, they exhibit these symptoms, but it hasn't been proven through testing that they indeed have an infection caused by SARS-CoV-2. So we gather a sample from their respiratory secretions using a long Q-tip, and this process is painless. It doesn't have any negative consequence on the person's body, which is just a little invasive because it goes inside your body, but it is basically just to gather this respiratory secretion. Then we analyze it and we wait for the results. The ones that come out positive are cataloged as confirmed cases, and of course the ones that come out negative are cataloged as negative cases. Here we have the distribution of the clinical state of these suspect and confirmed cases. Some of them are in intensive care, some of them have milder symptoms. Here on the lower part of the chart we have the proportion of, or the fatalities we have so far, and some of them are confirmed fatalities, but we have a number which is 123 right now of suspect cases that unfortunately have already lost their lives. We're still waiting for confirmation of whether they were caused by COVID-19 or not. In very few cases, and this can happen, sometimes a person, we have no opportunity of collecting the sample at any point, the sample for the test at any point whatsoever. This is rare, but it happens. And what we do in these cases is that we establish a dictamination process by a medical committee. So even if the absence of a laboratory confirmation, if we have elements to reasonably suspect these people from having COVID, we will eventually classify it as a fatality caused by COVID. This is important to take into account. This has been a minority of cases, maybe 5 or 6 cases, because most of the other suspect cases are either confirmed or confirmed to have COVID, or they are negative cases. This is the fatalities chart. Here we have the number of accumulated fatalities, which is 650, and are represented through this black line, and the columns show us the number of fatalities that have occurred every day according to the date of death, and that are confirmed because we have a laboratory result, as I have just explained. These are the associated conditions, the comorbidity chart, and we will insist on this once more. Those people who have these diseases have to be extremely cautious, because compared to someone that doesn't have any of these conditions, you are at a higher risk of presenting complications. And we've said that it's more than common to have more than one of these conditions at the same time. And this is an accumulative process. That person who has 2 conditions that are unfavorable in this situation is exposed to a higher risk than a person that has just 1. And then if you have 3, then it's a higher risk than the person that has 2, and then the person that has 1. So you need to be extremely cautious with abiding by the measures. And the first measure is staying at home. Do not interact with other people. And those senior citizens out there, do not receive any visitations right now. If you have a senior relative at home, do not enter the room, do not go see them, especially children. And those people who are taking care of these senior relatives, not going to see them doesn't mean abandoning them. Be in touch with them over the phone. Talk to them through the internet. Ask them if they need anything, but avoid having direct physical contact. It is very important to be in touch because we don't want to leave them in a state of abandonment or of loneliness, because this affects psychologically and physiologically not only senior citizens but especially senior citizens. Now, it is more than common in our society that within families, sometimes what happens is the younger members of the family gather together, and the like parents, children, and nephews, etc., and the older members of the family become isolated. So let's avoid that. As another way of analyzing this data, we have these three categories that are somewhat arbitrary, but they are meant to demonstrate that especially children and adolescents are very, very unlikely to die because of this disease, even though we do have some cases, but it's extremely rare. But then it is very common for people from 25 to 59 to, comparatively, it is way more likely for them to die because of this disease, and even more so for senior citizens. We can also compare the fatality rate between states, and this allows us to observe the development of the disease in different regions. The reasons in which, because of which there can be such a variation in the fatality rate between states are very diverse, and they are hardly directly observable in real time. So, but it is a certain reference that allows us to see which locations, which states are presenting a higher rate, and this maybe means that they require to have special attention when it comes to their health services infrastructure. In this moment, with the exception of some particular regions that we have commented, in which there is an important saturation of the medical service infrastructure, the rest of the country, most of the country, it is having an increase in the demand for medical service, but we are not at the point of having a saturated health system yet. The risk is there, but to this day it hasn't become a real phenomenon. So this can talks to us. This talks to us about the fact that there might be some sort of delay from the part of the families regarding taking those sick relatives to the doctor, to the hospital. So if you have a sick relative that belongs to a high risk group, do not hesitate to go seek medical attention, because the earlier the better. So this comparison between the fatality rate per state could be related to this delay from the society and from the families from seeking medical attention. So take that into account. Here we can look at the mortality rate. This is the number of deaths related to the population, calculated on a basis of 100,000 inhabitants, and the distribution appears on this chart. It is, of course, an unequal distribution, and it has to do with the amount of fatalities that have happened per state. This chart is weekly updated. And here, this is the positive result rate, meaning what is the distribution of the positive results of COVID-19, meaning out of those people who are tested, which percentage test positive for COVID. So far it's 20%, but this varies week to week. And please be aware that this has some variation. Because remember that, for example, in week 15, this number was at 16 something, and now it's 24.6. So why does this number present variations? Because the cases are documented as soon as we get the positive results. So if we had some samples that were being processed when we presented the data, there are some cases that don't get taken into account for the statistic because they're still waiting for the result. Sometimes when we get the results, they are reclassified and the number that we had previously presented change a little bit. This is normal within epidemiological vigilance, and this happens all over the world because we are always subject to the results coming out. Here we can show you overall some information that we were presenting previously on different charts, because we want you to have an appreciation of the size of each of the sets that I'm going to talk about. Accumulated positive cases in red. Accumulated fatalities according to the date of death in dark blue. Recovered patients in light blue greenish. And the accumulated suspect cases on the orange line. So remember, the suspect case number has to do with people who are identified as possible infected patients, and then they get tested and they are either confirmed or denied as COVID patients. Some of those patients, 20% of those patients turn out to be positive, 80% are negative, and some of them unfortunately lose their lives. We can see how many have died and how many have recovered in this specific chart. We can also look at the suspect cases, which I have explained already what the suspect cases are. So we will be presenting this chart during the following days and weeks to observe the behavior of the epidemic. And we want to emphasize that the recovered patients are good news. First of all, because they showed they didn't have an important disease process. Second, because they didn't die, obviously. And because by having immunity now, they will help us to eventually end and complete the epidemic cycle. This is related to the technical mechanism of the epidemiological vigilance model. I won't go into further detail. At the beginning of next week, we will be talking about each phase. Remember, we started at phase 1, and we have measures that were associated with the contention measures. But then when we entered phase 2, we activated the epidemiological sentinel vigilance model, and then we adopted different measures. And we started using the infrastructure we have, and that we currently and previously used for monitoring the cases of influenza. When we enter phase 3, we will announce a new package of measures of prevention and control, but also some modifications to the current model of epidemiological vigilance. Meaning, when we enter phase 3, all the measures and the model we have will continue, but we have some additional elements that we have contemplated already and that are relevant for phase 3. So this is just for you to look at how the vigilance level works and what are the technical, administrative. So we have almost 26,000 medical units. If we incorporated the private sector units, we have over 26,000. If we don't take into account the private sector units, then we have 25,377. We have different kinds of units, general hospitals, specialized clinics, etc. They monitor not only COVID, but over 150 different diseases that are constantly being monitored in Mexico according to the law. And all of the professionals that work in these units, either those units be medical units, hospitals, laboratories, but all of the medical professionals that work in these units are required by law to notify any disease that is considered to be legally that they are legally required to notify about. Obviously, COVID is one of these diseases that is cataloged in the law to be of required notification. So, if these professionals, they identify these diseases, including COVID, then they have to notify, and then all of the different administrative levels have to see that they notify it, and finally we reach the federal level. So it goes from the local level to the federal level. That would be it. Thank you.
Doctor, buenas noches. Carlos Guzmán de ABA Noticias de Veracruz. Dos cosas. La primera, hace algunos días había por ahí una nota que mencionaba.
Yes, doctor. A few days ago we saw a report that stated that IMSS had bought some ventilators from Guanajuato, from the state of Guanajuato, but those ventilators hadn't arrived yet. Can you talk about this if you have the information? And also, unfortunately, yesterday there was a very unfortunate event in a news program in which we saw a TV host, a news anchor, who talked to the population and invited them to disregard your advice for the public measures of prevention. Yes, regarding the ventilator question, we had Dr. Solis who explained this in a morning conference a few days ago, and there was a. So I think the situation has been explained. I don't have any additional information. If we're required to do an official press release, we will do so, but I don't have nothing to add to this time. And with respect to the work we do every night here, this work represents the efforts of all of the federal government, not only the Ministry of Health, all the federal government, and to synthesize, it represents the work of the whole country, of the whole national health system. As I have just illustrated, the information that we have at the federal offices comes directly from the medical units. Each of the doctors and nurses that provide medical treatments and medical services are the ones who are generating this information. And I want to say, and because of this, I want to express my gratitude and my respect to all of those medical practitioners and health professionals out there for being so responsive and being so responsibly developing and doing engaging in their duties. So thank you for that. But also thank you for contributing to information, for generating data, because each of the data that you generate when you notify the epidemiological unit of your hospital or directly through the online through the online platform, or giving this piece of information to the local administrative authority. All of this generation of data allows us to have a model of analysis and vigilance throughout the country. So thank you for generating this data, because thanks to you is that we can come here every night and present the information to the public. So within that context, it is an honor to me to be able to come here every day from 7 to 8, because I can give a voice to all of these thousands of professionals that work on the field, that gather the information. I am providing a voice indirectly to the state authorities, because it is the information provided by the state authorities, the one that I present here. And as we have said, as we have always said, but specifically in the context of this pandemic, it is very important that the population has clear and direct access to information in real time. If they have this access to information, they have to make better decisions to protect the health of their family, their neighbors, their communities, and all of us. I have said several times that these control strategies are not only an individual ethical, a matter of individual ethical concerns. It's also a technical administrative process, and that is why we have made all of this information available to the public. And let's not forget that generating this information has a cost, because it's a number of salaries that we have to pay to the people who work on the fields, for the analysts who collect the data, who analyze the data, who provide the models, and also the operation cost, the maintenance of the servers, of the computers. So who pays for all of this? All of us pay for it. All of the citizens who pay their taxes, also the companies, the businesses that pay their taxes. I think most of them pay their taxes, and all of them and all of us pay for this information. So who owns this information? All of us. And it is for this reason, and this is historic in a way, this hadn't happened in the history of epidemiological vigilance in Mexico, that was established in 1881. In July of 1881, the epidemiological vigilance of Mexico was established. That's where the first document that established the building up of this system. This first document appeared in 1881, in July. And we have made this information available in the most advanced formats that exist nowadays. For example, the map, the interactive municipality map, is a free direct access platform. You don't need to pay for it. You don't need to register. And this information is updated every 24 hours. And we will continue with this labor. I think it is important for everyone to have access to these data that are a public good. Thank you. Could we have someone in a different conference that can talk, that come here and talk about the ethical handling of the dead bodies? Yes, of course, we will prepare someone and to come and talk about that, and then we will have him or her. Thank you, Doctor. A few minutes ago, the Ministry of the Interior and the General Health Council said something about the TV. I'm not quite sure I'm not quite sure what they meant with the release they just Okay, and I also want to ask you if each institution is responsible for examining and guaranteeing the quality of the personal protection equipment. And this, I'm asking you this because I interviewed some medical professionals who said that they had received N95 masks that didn't have a proper certification process. So they are kind of concerned about this. Who guarantees the quality of the protection equipment that our doctors and nurses are receiving? But you're talking about the warning to the media. I have no information about that, but we can talk about it. Yes, tomorrow. And regarding who ensures the quality certifications of the material that is of human use that is being used within hospitals, that would be COFEPRIS. COFEPRIS is the national institution that is in charge of guaranteeing that. And COFEPRIS provides the health authorizations, and it happens all over the world, and it happens in Mexico, that sometimes in the face of an emergency we have an accelerated procedure situation, but this doesn't mean that we do not comply with the proper requirements. But COFEPRIS is the one in charge of guaranteeing the quality of these equipment. Would it be possible to have questions from other journalists that are not here so they can have a voice as well? And can we have an estimate of how many lives we have saved by the implementation of the control strategy? And also I want to ask about the protocols and guidelines for child care. I like your question about the saved lives. Yes, we can present an estimation precisely through these mathematical models that were facilitated to us from over 7 scientific communities coordinated by CONACYT and who come from universities and research centers all over the country. We do have a frame of reference. If you were here on Thursday, you will remember that we presented a very sharp epidemic curve that reached the 30,000 cases. And that was the hypothetical situation of what would have happened if we didn't have any mitigation measures. And currently we have a projection of what we think will happen, which is a way more flattened curve, which is this green curve that is very inferior in number of cases. So the comparison that could allow us to estimate the number of avoided cases and the amount of lives that were saved is the comparison between these two curves. And we can make the comparison. And thank you for the recommendation. We can do this, we can prepare this data in the way of a real-time report, because we have these two projections of what would have happened and what is happening every day. So I think that is a good idea. Let's focus on that, and we're going to do a special segment on that information. And this will be also very encouraging for the population, and it will allow us to reiterate, and I have been saying this, and thank you for the idea, we can accomplish this if and only if we stay firm, stay disciplined, stay acting in an orderly manner when it comes to abiding by the mitigation measures. So this means stay at home. Stay at home. If you stay at home, all of you, unless you belong to an essential economic sector, but otherwise stay at home. If we maintain these measures, we will succeed. And we can present the information daily of how many lives we are saving. Thank you. And the recommendations or changes in the protocols and guidelines for child care, there are no changes. It's very good news that we have had access to scientific evidence coming from other countries and from here that indicates that childhood is not a period of life that has that presents risks of complications for this epidemic. So we don't really know the reason for that, but fortunately that seems to be the case. And talking about the symptom of the loss or impairment of smell function, this could happen sometimes. It is one more sign. It's an accessory symptom, as we call it. So if a person has a headache, coughing, fever, and on top of that has other symptoms that are like red eyes or muscle pain and the loss of smell, this can be considered as a COVID compatible symptom. Thank you. Laura, and then we'll continue. Yes, two questions. First of all, do you have the number of people who have survived COVID? And what is the monitoring of these cases that has been implemented to monitor this immunity that you've been talking about? And what's going to happen with these cases later to end this pandemic? And second question, I've been interviewing a lot of attorneys and they had talked to me about a topic that we have barely talked about, which is the situation of children of divorced parents. What happens to these children that are a week or a few days with one of the parents and then they have to go to the other parent's home? Is there a risk involved in this process? Because the attorneys have told me if the parents fail to comply with taking their kids to the other parent's home, they could be facing charges. So also, third question, there is currently a law being discussed and the legislators are meeting and we have 128 legislators that are gathering for discussing this law, but we have recommended to avoid gatherings of over 30 people. So do you think some measures should be implemented regarding this? Let's talk about the last question first. This amnesty law, that is the one that is being discussed, is very important. A few days ago, one of your colleagues asked me if we had considered a process of pre-release, of pre-liberation for inmates, for federal prisons or preventive prisons, all sorts of prisons. In that moment, I said no, because the proposal of this law hadn't been developed sufficiently yet. So I had to wait to see the developments of this law proposal. At this moment, I see that this topic has continued to develop, and from a public health perspective, yes, it could be a useful element to reduce the population of prisons, because if we have a decrease in density, it is easier to have preventive interventions, and also there is a lower risk of disease propagation. So I'm happy to see that this law is advancing. Thank you to our legislators who are the ones handling this at the moment. And talking about the sessions, I think that they were considering doing it virtually or using auxiliary devices that can allow a remote session, but I think they haven't come quite to a decision yet. 128 legislators is a substantial number, but it is a manageable population within an enclosed space. Do not forget that we have official guidelines and protocols for the handling of enclosed spaces, so it's something that can be controlled. So thank you to all of the commissions that elaborated such protocols and guidelines. And talking about the children of divorced parents, like in any other community, yes, of course, the fact that a child has to go from one home to the other constantly could contribute to contagion. It really depends of the specific situation, but of course this could contribute to the risk of transmission. So those people should be especially precautious, and specifically if one of the parents presented symptoms, then they are morally but legally obliged by the law to inform the other person so they can take the necessary precautions. And talking about the recovered patients, it is the graphic that we have presenting for over 10 days. I just presented the graphic. It's over a little bit over 2,500 people. That accounts for 40% more or less of the overall confirmed cases. These people develop permanent immunity. But we have also said that in the world we don't have robust enough scientific evidence yet to guarantee that they will have permanent immunity. By analogy with other viruses, including other coronaviruses like SARS and MERS, we think that it will give us permanent immunity. No more time for questions because it's almost 8. I want to give a general message. We still have ways to go for the end of this epidemic. We need to maintain our mental quality and our spiritual quality to maintain our unity, to continue to be together in this. Any situation that can be distracting, that can be a distractor from our main objective, that is working in close cooperation, the public sector, the private sector, the social sector, the government, federal government, state government, the non-organized society, all of us have a role to fulfill in this epidemic for the public good. So I think it is extremely important to be calm. It is not rare and it is not surprising, and we shouldn't be concerned that sometimes emotions are running high. It is a perfectly human response to feel fear, anxiety, and even to be led towards aggression. So this is perfectly human, but let's try to prevent it, because if we show fear, we can propagate that fear and we can destabilize others, and then we will have a loss of clarity. So this is the message I want to give today. I want to say thank you with all my heart to I want to thank the support of the President of the Republic. I'm very privileged and very honored that he referred directly to my person, to me today, but I don't see it as myself, as him referring to my efforts alone, but to the efforts that I represent of the whole community that is doing a lot for the handling of this pandemic. Thanks to all of you who are staying at home, who are abiding by the measures, and who are paying attention. We still have 6 weeks at least of this epidemic, and we'll go through them successfully if we maintain a calm spirit. Thank you very much.